All right. Good morning. Thank you so much for having me. I'm very, very excited to be here and to talk about some of my favorite topics within my specialty. And so, as Rachel said, this is going to be a very interactive session. So I hope you've had your coffee this morning, because I am going to be asking for a lot of audience participation. And I've got two toddlers at home, so I can wait until the cows come home. So please ask questions. I do bring other topics to talk about if it does turn out that you guys don't have any questions. So that won't be a problem whatsoever. Louder. Got it. Okay. So anyways, let's get started. I'm also a bit of a pacer, so don't mind me kind of just walking around. All right. So as Rachel said, my name is Alejandro Velez. I'm a pediatric gastroenterologist. I've trained all around the Northeast, University of Maine for college, Vermont for medical school, and then the Bronx for residency, and then most recently Cincinnati Children's for my fellowship. I joined the faculty at CSMOT this summer as their motility expert, and I am in the process of starting our motility program up here in Michigan, specifically for pediatrics. So if you have any specific questions about what that looks like, I'd be happy to answer those as well. So this is kind of loosely our agenda. I've picked 3 essential general topics to talk about. And I will give you 4 or 5 slides about those things to kind of just introduce the topic and maybe spur up some thoughts and questions. And then I will have a slide to kind of prompt you all for questions. This really should be conversational. So yes, so the final slide of that section will be a prompt for you all with some discussion questions so that we can talk, okay? So let's get started, shall we? So what does the literature tell us about what the most common issues are in your kids? You know, there's not a lot in terms of clinical descriptions in the literature, but there is this wonderful study that showed that in their population, and not surprisingly, constipation and reflux tend to be the 2 most common conditions that your children come to us with. And so those are, I'm going to be spending some good amount of time talking about those 2 things. But I also, you know, I found it very interesting that discomfort is kind of so low in this list, and I can't tell whether that is because we underreport it, or if it truly is because you know, your children are not able to tell you when they are experiencing pain. And so that's something that we can talk about, but I expected, and I expect in general, actually, for that to be a lot higher than it turned out to be for this specific study. So let's talk about poop. Okay, I sometimes feel like I am a glorified plumber with some of the things that I do, but this is actually my favorite topic to talk about, believe it or not. So constipation. It's not just hard poops, you guys, okay? We think about more than just the frequency of stooling. We think about more than just the consistency of stooling when we talk about constipation in general, okay? So there is this wonderful nonprofit organization called the Rome program, and it's a nonprofit organization that spends a lot of time thinking about how we can standardize sort of these common, very common GI disorders, specifically in this case, constipation. So this is actually the Rome criteria for constipation, and you'll see that the asterisk says that you must meet, you know, at least 6 months with 3 months kind of nonstop. All of that we have to worry about. Don't worry about that part. Look at what's listed on there. A lot of this is stuff that we all know, right? Straining, hard stools, you know, sensation of incomplete evacuation. These are all the things that we're thinking about as pediatric gastroenterologists as we're making the final diagnosis of constipation, okay? So your child could be going every single day, but if they're passing softball-sized stools, that's a problem, and that is a constipated child in my eyes, okay? Don't be fooled. Liquid stools can still mean that your child is constipated. It's a tough thing to get your head around sometimes, right? Your child is going every single day. They're having liquid stools. How could my child possibly be constipated, right? There's this concept of encopresis. And again, going back to the whole, I'm essentially a plumber, right? If there is a clog along the way, there's a large blockage of stool, the newer, softer stool is going to leak around it. Worse yet, if that stool ball is right near the rectum and is stenting up the child's anus, that is just going to continue to flow, okay? So I can't tell you how many times I've seen families that tell me, how can my child be constipated when they're having liquid stools multiple times a day? And then we do an x-ray, and sure enough, there's a big old stool ball right in the rectum, okay? So keep those things in mind. Now, why are your children having constipation? Unfortunately, there are many things associated with the syndrome that put your child at risk of becoming constipated, okay? And this is just a short list of some of the things that I think about when I'm seeing your children and children with other genetic and neurodevelopmental disorders. But hypotonia is a big deal, okay? Your colon can't do it alone. It requires your muscles, and not just the strength of your muscles, but also the coordination of those muscles to be able to defecate appropriately. So we know hypotonia is a big deal in your children. That's actually a big deal in constipation too. That sort of coordination of those muscles to be able to poop, that's also a big deal, and we call it dyssynergia. Going back to what I initially talked about with are your children in pain? Are they just very stoic? I guarantee you they also have an altered sensation in their GI tract, okay? And so that can actually be a problem for constipation because they may not be able to tell that it's time to poop, okay? So that's something to keep in mind. The previous lecture gave us a wonderful kind of insight into some of the behaviors that your children struggle with, and withholding behavior is one of those, and that leads to chronic constipation. So those things are some of the things that I think about when I see some of your children. Hypothyroidism, this is a common condition in the syndrome, and if you're seeing your PCP, your pediatric gastroenterologist, the medications aren't working, and you haven't checked their thyroid, that should be the next step.
Paige takes thyroid supplement. I was never aware, until right now, I didn't know that they were interacting. So are you saying that if her thyroid wasn't being treated, that might worsen the constipation?
100%.
Okay.
100%, absolutely. And in fact, it's one of the things that, so kind of taking all other things aside, constipation, functional constipation is the most common condition in children, okay? The most common GI condition in children. And for the most part, the first step is treat them, okay? Because chances are they're withholding, they're doing, maybe their diet is not the best. Next step, if that medication isn't working, check for these things, okay? So hyperthyroidism is on a long list of conditions, systemic conditions that can lead to constipation, absolutely. So making sure that we're testing we're testing the thyroid, and if they do have a thyroid condition, making sure that they're being well treated, okay? So those things can lead to constipation. Speaking of medications, like I said, a lot of your children are anti-epileptic medications and such. Those impact the GI motility, and so that can also lead to constipation. And then the combination of medications in and of itself can also either dehydrate your child or, at the very least, tell the colon to remove more water from the stool. Dehydration. big concern in constipation, and then obviously a low-fiber diet and prolonged immobility. Not only do you need the muscles of the gut and the pelvic floor to poop appropriately, you actually also need to be able to be constantly moving to move your gut. So I'm going to give you a little bit of insight in how a pediatric gastroenterology that's worth their salt should be treating constipation. Okay, we use this kind of pyramid type treatment scheme where the first two rungs, the first two parts of the pyramid, which hold up the rest of the pyramid, are, in my opinion, the most important, and the ones that are going to be tried and tried and tried again. Okay, so education. What does that mean? Every single time that you're seeing your pediatric gastroenterologist, they should be reminding your child of the importance of frequent toilet sitting, the importance of using kind of post-meal times as a good time to poop. When you eat, your colon knows that. Your rectum knows that. And so that's going to be the best time. It's preparing for you to defecate. That's a normal reflex. And then the next rung up is the combination of osmotic and stimulant laxatives. Your Miralaxes, your Senna, your Bisacodals, those are all going to fall there. And those can be given either in an oral or in a rectal form. So the majority of pediatricians and pediatric gastroenterologists are going to be spending most of their time there. And usually when you start getting beyond that is when they start referring out to specialists, okay? So the next rung up is sort of these new medications that are coming down the pipeline from research. And we're very thankful that there is so much research in this field because we are seeing new medications in this sense. Medications such as Linzess, which just got approved, FDA approved for children 6 and up, is going to be fantastic. And so these are the medications that are kind of making their way through the ringer, so that and being found to be safe for our children. So those are options that are becoming available slowly. The next 3 steps probably represent about 1% of all children. Okay. It is very rare for us to have to go on to the next 3 rungs, okay? And usually at this point, we're talking to colorectal surgeons and we're talking to specialty centers, okay? And this is what I'm hoping for the Michiganders here to bring to the state for pediatrics because it is sorely needed. Antegrade continence enemas, or ACEs, you'll sometimes see kiddos with buttons on the right lower quadrant. And they'll look exactly like a G button. Those are sarcostomies, and those allow you to give high volume enemas kind of the other way around. So instead of doing it backwards, you're doing it forwards. Okay, that's what that means. Nerve stimulators. I know of 2: sacral nerve stimulator, which is a spine stimulator, and then there's a tibial nerve stimulator, which is still under research that help kids poop and pee. And then finally, surgery if we find that we need to give the large intestine a rest, or we need to remove parts of the large intestine that are not working. We would be talking about that as well. Okay, so just to give you a little bit of insight as to some of the things, the treatment options, and there are many treatment options, but guys, constipation is not easy to treat. Okay, and I tell you, it's something that a lot of us as doctors kind of poo-poo aside. But it really is very difficult to treat. And the longer standing that constipation is, the more difficult that it is, okay? I don't take it lightly. So, I've talked enough because this just happens to be my favorite topic to talk about, and I could continue to talk your ear off, but I want to hear from you all. Bring up any general questions about constipation that you have, management options. I've given you a few things that maybe you want answered, and I'm happy to answer them as well. But please, if you have questions, bring them up now.
Good morning. We have Alice on a fairly good protocol now that we've done for almost a year, where she's getting Senna at night, and then we do a DocuState enema in the morning and have her just sit on the toilet. She is totally diapered, though, other than that. My concern is she's a horrible drinker. We have tried everything to make her drink more and be more hydrated, and I add liquid to her foods as well as much as I can. what we see, though, is we think whenever she gets off even the slightest bit with her drinking, or like when we travel or whatever, that she definitely struggles more with that constipation. So what is the best way with the protocol, within the protocol that we're using, or adding something else, for those times when we know she's probably more backed up, and the normal day-to-day is not quite enough?
You bring up an excellent point, and thank you so much for sharing the specifics of your child. So I'm very proactive with my families, and I encourage them to use their best judgment in regards to titrating those medications, okay? I really empower them to, on a day that maybe is not, that maybe you broke out of the routine. So for example, maybe yesterday you went to the baseball game, right? And it's hot, and you can make, I encourage and I teach my families how to make medication changes, okay? But also remember, water doesn't all have to be just water, okay? Your food has a ton of water, right? So if the act of drinking is a problem, and you fear that you're not gonna be able to have your child drink enough, encourage, specifically I'm thinking of fruits that are, high in water, and vegetables that are high in water, and they may be more willing to take those. And those are like, 90% water sometimes, right? I'm thinking specifically of something like watermelon, for example. It's sweet, it's delicious, it's healthy, and full of water, okay? So if the drinking is a problem, find some foods that they like that have a lot of water. With that said, even with, no matter how hard we try to get them to drink, to try to get them to eat, maybe it's just an off day, I would encourage you to maybe rely on medications that don't require so much for the kid to be hydrated, okay? And I'm thinking specifically of the stimulant laxatives, okay? So those do not require necessarily, or the mode of action is not to bring water into the colon and to moisten and soften the stool. They're actually to tell the colon, the large intestine, to move along, okay? So having in your back pocket a stimulant, I'm thinking specifically of Senna or Bisacodyl, okay? Those are two medications that can be used that are very safe and can be used on an as needed basis to get that colon to move, okay? Correct. Yep. Sorry, do you want to use the microphone? So
Would you do that in addition to the rest?
yes. Yep.
Okay, so like if we do our normal protocol and it's like, oh, you have not gone enough, then give the stimulant.
Absolutely. And I always give my families a rescue plan. So I give them certain criteria based on whatever their child's normal bowel movement frequency is. And then I tell them, okay, if they don't meet X, Y, and Z, I want you to give this medication. And it's typically in the form of an enema, though not always. But that is because what you want to prevent is whatever is sitting in the rectum to dry out even further, right? Because then that just creates a cycle, a vicious cycle that's just going to make things worse.
Okay, so you would prefer that over increasing the oral Senna?
Yes.
Excellent, thank you.
Hi. My daughter's doing daily Miralax. Typically, we have a stool, sometimes multiple stools a day that are soft, not liquidy. But anytime we do like an x-ray or anything that looks, they always say there's a lot of stool in there. So I'm assuming that she's got a blockage like what you're talking about. How do you know? I mean, do I just start increasing the Miralax until we get more liquidy? What do you know? What do you do?
Fantastic question. And it brings up a few very important concepts, okay? If I were to take an x-ray on every single one of you, I guarantee you the radiologist would read it as moderate to severe stool. I kid you not. It is not an exact science. And better yet, depends so much in the way that the x-ray is taken, whatever the child is wearing when the x-ray is taken. And guys, I mean, that's the point of the colon, is to store stool, right? The radiologist is just reading what they're seeing. They usually don't have any additional context, okay? So that's why it's important when, say, somebody like me asks for a x-ray, I need to keep the patient in mind as to whether that makes sense for that child, okay? So things to look for. If you're concerned that your child is going daily, the Miralax is, they're taking their Miralax, they're well hydrated. If they're not having pain with pooping, blood in their stool, passing large caliber stools, those are the things that you're going to be looking for, okay? So if you're seeing those things, then they're constipated, and then it is possible that you may need to up their dose. It's possible you need to do an at-home clean-out. It's possible you need to add a stimulant, okay? Don't rely so much on the x-ray, all right? The x-ray is only a piece of the puzzle. And I'm in the pediatric gastroenterologist camp that says less x-ray, the better, okay? Because it only helps in very specific situations. The diagnosis of constipation is a clinical one, not a radiologic one.
Okay, thank you.
Of course.
We haven't gone to the gastro doctor in forever. She has reflux and she has constipation. We treat it with Miralax. She seems okay. I mean, we know when she's pooping because she gets quiet and concentrates. But should we be going to the gastro doctor? They really, in the past, she's 21, by the way. In the past, there wasn't much to talk about.
I think you answered the question, right?
Okay.
If it's not causing any issues, then there's no need for you to, get everything ready to go to the doctor, spend who knows how long in the waiting room, and then see the doctor for 15 minutes or something. Like, if you don't have to, don't put yourself through that, okay? It's when it disrupts your daily life, their daily life. It's when it prevents them from doing the things that they were enjoying previously. It's when it's causing pain, when you're seeing a lot of bearing down, when you're seeing them turn red when they go poop, when they see them passing large stools, right? Like, those are the times that I think you should start thinking about going to your gastroenterologist. I guess in this case it would be an adult for her, but also rely a lot on your pediatricians and your general doctors. They this is common enough that they see plenty of this too. And if you've got a good general doctor, they should be able to manage the majority of these things, and their availability is usually better than the subspecialists. So if things are going well, stick with it.
Thank you.
Mm-hmm.
So I have a couple questions. My daughter's 30. She was constipated as a breastfed baby, and we had a lot of people that just dismissed it. And when she was starting to potty train, she was able to poop in the potty, but it was always because it was so hard she could feel it. Once we got it kind of more under control, they did say she had ankle paresis, so we were dealing with that. But she has problems then with it always kind of leaking out. And she will do some, but she'll always do it in her brief. And then every once in a while she'll just have, it's very soft, but she'll have a mass that will come out. And then it will take up to 5 days for her to start pooping again. So is there anything, and I'm thinking that she can't quite feel down there to know how to do it. What do we do? How do we find a good gastroenterologist that will work with us? Because a lot of us just said, oh, it's just constipation, and dismiss it.
Yeah. No, I think it's very easy, again, to dismiss constipation as just constipation. I think I have right there. When is it not just constipation, right? It sounds like your child is constipated, just based on your description, right? And so it may be time to start thinking about talking to either your general doctor or your subspecialist about upping those meds, perhaps doing a clean out, that type of thing. Okay. So you want to find somebody that's more comfortable with with the high doses of these medications that patients with similar symptoms might need, right? And that requirement may change day to day, as you know. And this is why I encourage and teach my families how to make changes on the fly, so that you don't have to send me a MyChart message or call my clinic and then wait 2 days for me to answer you. Okay, so it's really becomes about finding somebody that feels comfortable handling these medications and that teaches you how to handle those medications. The sensation part is huge. Okay, not just the sensation, but also the coordination, right? So what I would suggest, depending on the level of her functioning, would be to look into pelvic floor physical therapy, okay? They can do some wonderful things with biofeedback, where they have electrodes that are placed on sort of the pelvic floor area, and they can tell which muscles they are contracting or using when they're pushing to poop, and they have certain techniques to teach your child or your adult child what it should look like when they're trying to poop, right? Because it's a huge number of muscles that you need to be able to contract to be able to defecate properly. So those are my initial thoughts, and we can talk more after if you like.
Okay, thank you.
Let's do one more question, and I promise we'll talk more after. I just want to make sure we get to the other two topics that I think are just as important, despite the fact that I love this topic. And I could talk for the entire time.
I am a little interested. You mentioned there's a new medication that's coming out that's for children. I'm interested in hearing a little bit more about that, because we are doing a lot of the things. She does exhibit a lot of control. She likes to poop in a very specific place. So we're here, and it's been 2 days now, and we've got to do the enema and do all of our emergency. She takes lactulose. We do the bisacodyl. Really, poop controls everything about our life. And she gets very, very behavioral when she doesn't feel well. And so I am interested to hear more about the new medication.
Yeah, so there are a number of medications that are, so the adults get all the nice stuff, right? They get all the brand new medications, they get all the cool stuff. So we kind of have to wait. Usually the pediatric side is waiting for at least 5 or 10 years before those medications make their way down. And so the medication that I was talking about is called Linzess, and it's the generic name is linaclotide, and it's a medication that works in a different part of the colon, and it does two things, or has been found to do two things. So it brings, like all other medications, and brings more water into the colon to soften the stool, but it's also actually been shown to help with this chronic abdominal pain that some of some of the children exhibit when around constipation. So I literally like months ago got approved, FDA approved for 6 and above. As such, not every pediatrician or every pediatric gastroenterologist is going to know how to use it, but bring it up. Bring it up next time. It's a daily medication. It's not similar to like the Miralaxes and the Sennas where we can kind of make changes on the fly, but it can be a good kind of everyday medication to keep them stable, and then you can use those other medications on days that are maybe different, or on days where she hasn't gone for multiple days.
Great. Do you mind spelling it for us, please?
Yes. LINACLOTID, linaclotide. Yeah.
Did you find it? Okay. Thank you so much.
Of course, anytime. Let's move on. So the next topic I wanted to talk about very quickly was growth and feeding concerns. So there was this wonderful study that where in their population of patients, they were able to document kind of the growth as the child got bigger. And the first thing that I want to show you, and I'm sure you have all heard this when your child maybe was young or are currently hearing this, is your children have a tough time growing. Or is it that maybe it's not even a tough time growing, maybe it's just that they're not meant to be as big as the average baby, right? And that's something that I think pediatrics is finally coming around to, and we're doing a lot with other syndromes like trisomy 21, Down syndrome, where they have their own growth chart, okay? And so it's hard to compare children with neurodevelopmental and growing syndromes to a normal child. And I shouldn't use the word normal, I apologize. To a regular child, a child without the syndrome. But we know at least that they don't grow at the same rate and in the same way that those without the syndrome. Okay, and that's what's shown here. So the young in the younger years, they really seem to have a little bit of weight faltering. And then interestingly, as they become older, older children and teenagers, it seems to be that really the females tend to be either obese or kind of smaller, on the smaller side, but males tend to kind of level off of the curve. So this is all weight, and you can see circled there the populations that I'm talking about. So why is that? And a lot of these lists and reasons why these conditions happen are going to be very similar. But I talked about the genetic predisposition for short stature and low weight, right? It may just be that your child was never destined to be big, okay? And that's okay. As long as a few other things are going well, we really should not be basing it entirely on the growth chart that are for children without this syndrome. Okay, in an ideal world, we would have a 1P36 growth chart. We don't have that yet, but at the very least, keep that in mind. Nonetheless, we know that your children have issues coordinating their swallows. They have issues sometimes with a cleft lip and a cleft palate, and despite it being repaired, they're still not normal cleft lips and they're not normal palates and lips, okay? So they're going to have some swallowing issues as well. A lot of your children have other congenital diseases, including seizure disorders, congenital heart disease, and then sometimes even kidney problems, okay? And so all those things consume calories, okay? So it may just be that your child is not meeting their nutritional requirements because they have these other things. On the other side, why is my child quote unquote obese, all right? Again, there's a genetic predisposition for them being short, okay? And so on a normal or on a typical growth chart, they are going to be, they're going to have a high BMI simply for that reason, all right? But we also do know that there are some maladaptive behaviors, especially later in life, where binging may be a problem. There's a concern for hypotonia. Again, the whole hypothyroidism coming back. All of these things are going to lead to high weights later in life. And then, again, the sensitivity issues. They may have a texture or a taste hypersensitivity that really restricts their diet. And sometimes, unfortunately, that leads to a lot of junk food and high-calorie, high-fat diets. So how do we combat this? Well, we have many ways of doing this, okay? And typically, it may or may not involve the use of a tube. All right, so for the children that are really having a hard time swallowing and are just not able to eat or drink the calories that they need, we may grab for a tube. We have multiple options, right? We have tubes that can be replaced that go from the nose to the stomach or from the nose to the small intestine. That's what the jejunum is. The jejunum is the second part of the small intestine. And eventually, if it turns out that they might need it for longer than perhaps a year, we may start thinking about something a little bit more permanent. I always call G-tubes semi-permanent because they can be removed. They leave a little scar, but you know what? If they graduated, they're now eating everything that they need by mouth, you can take that thing out and it'll close on its own. So I don't like to call it a permanent solution as a semi-permanent solution. And then another important part of this, and I think one that people don't think about as often is, we were talking a little bit about hydration earlier, but also, what if your kid's just having a bad day and does not want to take their medications, right? Some of these medications cannot be skipped. So these tubes can give us a very reliable way of make sure that they stay hydrated and make sure that they get their medications. It is not unusual for me to see a patient in the hospital as a consult, patient with seizure disorder that literally just needs a G-tube for their meds. It's out there, we do it, and it's a good use of a tube in my opinion. Thoughts? Questions about growth, questions about G-tubes, feedings, I'll take it all. I saw one hand going up and another one over here.
My son, this has been a struggle literally since he was born. So he started out with the NG tube in the NICU, kept pulling that out. A month into being at the NICU, they placed a G tube. He came home with that, and last year, in springtime, he had lost 15 pounds in a matter of 3 months due to unable to keep feeds down. So they switched to the GJ tube, which he has pulled out twice, the entire thing, in the last 3 months. So, you have to go to Children's for that and all of that. But that wasn't my question. My question is he's still on formula, and he takes his bottle feeds. He takes feeds by mouth. It's when he has our life has been like this. So when he gets to this point, then we obviously have to do the feeds through either the G or the J. Primarily the J. Whenever we do anything through the G, even medication, he refluxes because he also had a Nissen fundoplication done. And he's aspirated and got pneumonia twice this past winter. My issue, and I've tried mentioning this and trying to get a way to explain this to family. Everybody he should be eating normal food. He should be eating pureed food. Why is he only getting the bottle? And they don't understand. So explain to me how I can explain to them that this is what we have to do now, and that he is getting all the nutrition from the formula, and we're slowly trying to introduce the pureed. How do I explain that to my family so I have less judgment to deal with?
I'm sorry that you're being judged. I really am. That's and this is the trouble I feel like, unfortunately, with some of the people that we get exposed to, right? Is you're absolutely right. They don't understand. They have no idea. Neither do I. Okay, I'll be honest with you. I have two children, and I have my own struggles, but I have no idea what you guys are going through. However, you did a fantastic job at explaining to me exactly what is happening and exactly what your concerns are. Do that. Okay, do that. And I can tell that you do. I can tell that you do. Yes, and probably a lot. And so, sometimes it's really just about being frank with people and telling them, listen, my child has a very unique syndrome, and this is what I have found works to keep them growing, to keep them safe, right? Because you told me he's aspirated. Okay, that is a life-threatening condition.
Yes.
All right, he's had pneumonia. So in an ideal world, you really shouldn't have to explain yourself. All right, this is your child. This is how you do things. Okay, like that should be, and you're doing it under the care of a doctor. Like that should be done. That's it. End of topic. But it isn't. So do what you just did to me. Explain things like this. Be frank with them. Look at them in the eye and really tell them, listen, this is what works for my child. This is what works for our family. I think where the concern may be coming from whoever you're speaking to, is that by just doing liquids, and I'm going to leave this for my speech and language pathologies colleagues to kind of better explain, but you may be at risk of losing some of those skills. Some of those protective skills, right? So that oropharyngeal skills that we use for swallowing, for protecting our airway, those types of things, it's possible that may be where it's coming from. That they're worried that your child may not get enough practice with those things, and so try to see it from their point of view, but also don't make any excuses. Okay, seriously, if this is what's working for you, and it's helping your child grow and be healthy, that's where that ends.
My aunt and uncle, I had two cousins who now, with them seeing Leland and us getting the genetic testing on Leland, both of my cousins passed at very young ages. My first cousin was 13 when he passed, and then my next cousin, Tiffany, was 19 when she passed. We know that now they had 1p36. They did not have to have G tubes. They didn't have to have NG tubes, no GJ tubes. But even them, my aunt and uncle, it's given them a lot of closure to see Leland progress. But it's hard. It's most hard with them explaining to them how Leland is different from what my cousins were.
Right. Yeah.
So I don't know. That one's a more slippery slope.
Well, let's talk after, and we can maybe brainstorm some language that we can use. But you hear this from your geneticists. This just because they have a portion of this chromosome deleted does not mean everybody's the same. It's the extent of how much that deletion is. It's how the body then adapts to that deletion. Every child is different, and their conditions are different. And so use that language. I think that might help. And then we'll talk more and we can brainstorm more.
Great, thank you.
Over here. Back here? Right there.
Hi. So Anthony has had a J tube since he was about a month and a half old.
Dedicated J?
Dedicated J. He will
it.
probably have a J. I don't want to say for the rest of his life, but from a neurological standpoint, it's most likely it will be. But he has developed an esophageal stricture that is pretty significant, which is why I say it'll probably always be a J. But I guess my question kind of ties in with the constipation you were talking about. So he's on a 24 hours continuous feed. That's because they can't get the J in the jejunum, it's in the duodenum. So can that contribute, I guess, to constipation because his gut isn't moving? He doesn't have any gastric emptying. We've done gastric emptying studies. So I guess, does that contribute to the constipation? And also, I guess, I don't know. I guess that's my question. I kind of wanted to ask that.
Let me take that on.
It kind of ties in together. It's not really just like.
Let me take that on because I think that brings up a very interesting point as well. So I would not expect it to. Okay, continuous feeds should not necessarily contribute to the constipation with everything else being equal. Okay, so everything else being normal, no, it shouldn't. However, from just the basic facts that you've given me, I have a feeling that it's not just that. Okay, it's very possible that your child, based on the fact that they have a delayed gastric emptying to begin with, my guess is the downstream motility is also affected. Okay, yeah. So it may be that for your child, it may be that they need either a different type of constipation medication, or I think it may be time to start thinking about what is happening from a coordination and strength of contractions in the small intestine and even the large intestine, okay?
So what are some things that I could ask the doctor for? Because I feel like his main issues are just gastric and neuro issues, you know what I mean? And I know that they are directly correlated with each other. So I guess what could I ask his GI doctor for just to see how we can maybe help him get to a higher rate, less frequency,
It depends on where are you from?
We live in Ohio.
Ohio. Oh, actually, perfect. So, and the only reason I say that is because there's 5 children's hospitals in Ohio.
Yeah, he goes to Rainbow Babies right now.
Rainbow.
That's
Okay,
his,
fantastic. So, yeah, let's talk more after this. But
Okay.
Nationwide and Cincinnati Children's
Yeah.
are both fantastic centers that have motility and neurogastroenterology services. that may be able to lend a helping hand. So I'm thinking specifically about trying some prokinetic medications and potentially doing some manometry studies. Okay?
Okay, thank you.
Yep. One more question on this topic, and then we'll move on.
I know. So my son not only has the 1P36, but he also has the cerebral palsy on top of it, and he also has the gastroparesis. So he's been on everything from Miralax to Cinna to suppositories, and now the doctor didn't like that I put him on suppositories without their, consent or whatever. And so they're like, no, he needs to be on the enema, not a suppository, because it'll mess with his electrolytes. So can you explain to me, I asked them to, but it was like, I wasn't getting any clear answers of why that's a big deal, because the enema, like I told the doctors, cause him runny stools, and it's so bad because it'll go through his whole outfit and onto everything multiple times a day. Where the Cinna, the suppositories, they get the stool out and it's soft but yet formed. So why is it that I should do what the doctors are saying, and I'm thinking this don't sound right?
Fair, and I think you have some great insight there, and not knowing the specifics, and you and I can talk more about the specifics if you'd like later, but not knowing the specifics, there really shouldn't be any difference between the enemas and the suppositories. They're typically the same medication. Okay, there were some concerns. I want to say maybe 10 years ago, about a specific type of suppositories that was causing some kids to have electrolyte abnormalities, but we weren't sure if that was just we saw it because we were looking, or was it actually affecting them? Okay, so maybe that's where it's coming from, I'm not sure, but currently, and those were taken off the market, currently, everything that we have to our disposal, again, not knowing the specifics, I'm not sure if they maybe have some kidney issues or other things that may be worrying them, there really shouldn't be any difference between the mode of administration. So in other words, there really shouldn't be any difference between suppositories and enemas. That should not make the difference. It's the medication that should. So whether we're using a bisacodyl enema or a bisacodyl suppository, it's the same medication. They might work a little bit differently for your child, depending on, can they hold the enema long enough versus the suppository kind of just dissolves on its own. But in terms of the electrolyte abnormalities, I don't expect that to play a role. So let's talk a little bit more, and maybe we can get down to the meat of it, okay? All right. Last but not least, let's talk about reflux. So a little bit of an anatomy lesson here. So we are all familiar with the stomach, obviously. The esophagus is another word for the food pipe, which connects your mouth to the stomach. But in between, there's this lovely band of muscle called the lower esophageal sphincter, or LES. And reflux is a normal physiologic process. Every single time that you relax that LES to let food and drink pass, you're going to reflux. Every single one of us have had multiple reflux events since we've been here. It becomes a problem when it does it too frequently, when it does it at inappropriate times, and when it starts to actually injure your esophagus, your food pipe, and your stomach. Okay, so that's when we go from just gastroesophageal reflux as a physiologic process to GERD. This list is going to look very, very similar to some of the lists that we've been seeing, okay? But what predisposes your children to have GERD? Again, this concept of hypotonia, right? The muscles are just not as strong as they should be, and that includes even the smooth muscle that is around the lower esophageal sphincter. A lot of the medications that your children might be on might increase the acid secretion in the stomach. It might relax the LES inappropriately. So those are things that are putting them at risk for GERD. We've been talking a little bit about delayed gastric emptying. Things hanging around in the stomach for too long are going to make them more likely to be refluxed. And then for whatever reason, and we don't know why yet, children with 1P36 seem to have a higher frequency of hiatal hernias, which is essentially when the stomach slides into the chest cavity a little bit, and that weakens that LES and makes it more likely for somebody to have GERD. Unlike with constipation, with GERD in children, we don't have as many options, and it is just as hard to treat sometimes, okay? The difference is that the medications that we do have for GERD actually do a pretty good job at treating the condition. But what we typically like to start with is sort of some of these lifestyle changes. You've heard about reflux precautions, even in young babies. Keep them up, keep them upright for 10, 15 minutes after their feeds, small volume feeds, more frequent feeds, that type of thing. For the older kids, no food before laying flat, no food 1 hour before laying flat. Those are the type of lifestyle changes that I'm talking about. I'm sure you're all very familiar with some of these medications. Proton pump inhibitors, PPIs, ends with prazoles, and those are kind of the more heavy-duty medications that try to put a stop to the acid secretion into the stomach. And then our histamine receptor 2 blockers, which end in tidine, so something like famotidine, that tend to be kind of on the milder side, and they reduce the acid in the stomach much more gently. I heard at least one mention of fundoplication. So this is probably the only procedure that we have available that actually works at the LES. The medications are only reducing the acidity of the stomach secretions. They're not actually acting on the LES, okay? So if you have a weak LES, you may still be having frequent reflux, which may lead to discomfort, but it may just not be as erosive when they're on these medications. But the fundoplication is really the only thing that we can do to kind of strengthen that LES. We've heard about the Nissen fundoplication, which is a full stomach wrap around that area, but there's other options like a partial wrap, like the Dor or the Dupay, which are anterior and posterior partial wraps. Vomiting and retching is not always GERD. There may be something else going on, okay? Especially if we're really not, if we're not seeing improvement on medications, maybe they've already got a fundoplication, but they're still retching and they won't be vomiting, but they may be uncomfortable still. It may be time to start thinking about other things. And these are some of the conditions that we see in this population that may be associated with these symptoms, and so further testing may be needed. I'm sure you're all familiar with an endoscopy, so that may be a best next step. And I usually keep it pretty early in my diagnostic kind of toolbox. And then we have other things to measure whether this is truly reflux or not with pH impedance and then the Bravo technology that allows us to do that. And then the stuff that I do and I love, which is manometry, will allow us to see the gastroparesis, would allow us to if we need a true diagnosis of rumination syndrome, it will allow us to see that as well. And then contrast imaging for things like oropharyngeal dysphagia, sort of the coordination of the swallowing muscles, and then obstructions if that's truly a concern. All right, I think we have about 5 minutes. Let's do, if you have a specific questions about reflux, why don't we do that now? And if you don't, then we can just open it up for the whatever question you got for me type of thing.
Well, I have a reflux question. I don't see any other hands. My daughter got a Nissen at 6 months when she got her G-tube. G-tube's been gone for years. Nissen's not going anywhere. When she's ill, which is the reason I missed all of yesterday, sorry everybody, the night before she had an episode, can't vomit, retched all night. It's getting to the point where every time she has one of these, we get more up. Is it breaking? Is it opening? Is it just stretching? Is that okay? Or do I need to think about looking at it at some point?
It depends on how often it's happening, and it depends on what she's bringing up. Okay, so if you're actually seeing vomitus come up, it's very possible that the fundoplication may have failed, which is not uncommon. And in and of itself, it's not dangerous. Okay, it's possible that the stomach wrap may be loosening. It may have come completely apart, and that's fine. It just means that the fundoplication is gone. So it really depends on how often it's happening, what she's bringing up, and whether she's having other symptoms, right? So if you were telling me that this is happening on a weekly basis, it's really disrupting to her. She's in pain. She's complaining of pain right here or something, and having difficulty swallowing. It may be time to take a look. And I'm specifically concerned for erosive esophagitis, which is essentially just irritation of the lower part of the esophagus. That's really what we're trying to keep an eye on, because that's later in life, and I'm talking like into the 30s, 40s, 50s, that may turn into cancer. So it's something that we just need to think about. And I know I said the C word. I don't want you to freak out. Just in general, if these are happening frequently and you think that the fundoplication is failing or is weakening, it's not a bad thing to bring up.
Yeah, no, it's once or twice a year maybe.
Yeah.
But
I wouldn't
my
be cer-
thought is that I just didn't know if she got the Nissen in the first place because she was immobile, basically. She was always laying flat on her back unless I had her on a wedge, and that was the first several years. But now that she's up, I assume she's not reflexing because she's vertical now.
And you're probably right. You're probably right. And I think the fundoplication is kind of falling out of favor a little bit. And in my own practice, it becomes a kind of a last resort thing. In the past, it was used a little bit more liberally. And so a lot of kids were getting fundoplications more often than perhaps they should have been. And this is part of science, this is part of medicine. We learn from the things that we do as time goes on. But I think now we're a little bit more wary of who gets a fundoplication in the first place. So you're right. She probably doesn't need it anymore.
Thank you. My daughter is currently 33 years old. She had a fundoplication because of refluxing and a G2 placement when she was 1. So she now totally eats by mouth, but she has problems she can vomit now. So her Nissen is still there in place, but it's loose. She has problems with actually loose stools and vomiting. Sometimes a lot of vomiting, belly pain, nausea. So she's on like dicyclomine 3 times a day, Zofran twice a day, just to keep her kind of, normal. So I'm just wondering, it's kind of a different issue, I think, maybe, but I don't know if anybody else has this issue.
I guarantee you at least 1 or 2 families in here, or more even, are having a very similar issue. And so you and I would have to sit down and try to piece that apart a little bit more as to whether it's the constipation, if there is constipation present that may be leading to the feelings of nausea, abdominal pain, and vomiting, whether it's maybe that the Nissen has weakened and we're actually seeing some additional reflux, and maybe she has a little bit of an irritation in the esophagus. So it could be all of those things. It could be one thing or the other. So it's important for you. I would bring that up next time that she sees, if she has a GI doctor or just a general doctor, and to truly try to piece apart kind of what's what.
She does see GI, but the problem is when now she's an adult. So you have to switch all your doctors.
Yeah.
They don't get the history. They're not used to working with like kids like you do. So they don't know.
Yeah.
So she's been scoped from the top, from the bottom. They don't know why she's in pain all the time.
So let's talk maybe this afternoon or even after this, and we can come up with some ideas as to what may be happening. But I have a feeling that your experience is not. You're not. I don't think you're alone in this. And it may just be, and I say just, but chronic abdominal pain is also a concern in this population, and we have things that can help for that as well. Okay. For the interest of time, I'm gonna just say some closing remarks, and then we can decide whether we want to do more questions or move on, and we can talk later. So, we've brought this up multiple times, but every patient is different. Every child is different, and the way that the GI condition impacts their life is also different. And you are the expert in your child. You are the caretaker that sees them every day, that handles these GI conditions. So give yourself that term. You are the expert in your child's condition, and nobody else is. And do not let them tell you otherwise, okay? With that said, you do have a role to try to help us understand your child, okay? We don't live your life. Some of us, some doctors may not even have children at all, so they have sometimes no idea what it's like to raise another human being. So help us understand your child, advocate for your child in a respectful manner, and sometimes, if you have to yell and curse, that's okay, but just make sure that that you at least don't. We're not mind readers, okay? So please help us understand your child the best that you can, and don't be fearful of advocating for them. As we've heard, GI conditions are very common in this syndrome. Address them sooner rather than later. I have an easier time treating constipation that's been going on for a year than constipation that's been going on for 10 years, okay? So they may not be as disrupting as perhaps seizures and cardiac conditions and renal disorders, but they can be. And they can become a bigger issue. So address them sooner rather than later. And then finally, this is a relationship, right? The health provider to family relationships are very important, okay? And it's built on mutual respect, honest, two-way communication, and it needs to be, it needs to be built on those things. So talk to us, find somebody that will talk to you, that knows your child, that knows you, that knows your family, because truly that in the end is what leads to the best outcomes, okay? And in the end, this is why we do this, right? These are my two beautiful children who I think are going to be coming for lunch. So Mateo is the one that's his this picture smile. That's his new picture smile. So you tell him to say cheese. That's what he does. And then Nicholas is the one sitting down. He's one, and he's already got so much attitude. I love it. Thank you so much for giving me the time. Thank you for inviting me here, and I will talk to you guys after.
One quick question. What's your opinion on long-term omeprazole for reflux? Are there issues long-term with that?
Yes. Yes, there are. There is a good body of research that is coming out and showing that we underappreciate how I don't want to use the word harmful, because you always should be having a benefit and risk conversation with your providers about all medications. But I think we're realizing that the long-term use of these medications can bring on some additional concerns. And so I always review my patients' medications when they see me, and in my head I'm thinking, can we take this medication off? Can we wean it off? Can we bring down the dose? Can we replace it with something maybe a little bit milder? And that's something that you should be doing with your children as well. So my trials of PPIs, 3 to 6 months. If that's not working, we got to think of something else, okay? It's possible that they have long-standing gastritis or acid reflux that may be treated in a chronic way, but then we should be finding the lowest dose that works for them and that prevents them from having actual injury to the stomach or the esophagus. Okay, so there most likely is a reason why your child has been on a PPI for a long time, but that reason better not be that we have not reviewed the medications, okay? Because we really should be doing that. It's multi-pharmacy is a big problem in medicine, and we need to evaluate those medications every single time that we get a chance to.